Assalamu alaikum. As you all guys know, today I am back with the Sir Naghman Zuberi with a series of lectures. And today's our topic is dentine and its clinical significance. I would like to invite Sir to start this today's lecture. Assalamu alaikum, Sir. Hope you are fine. Sir, kindly start the lecture.
Wa alaikum assalam. Yes, I am very good. Thank you very much. So today we will be discussing dentine and its clinical significance. We know that dentine is there, and what is dentine, but why is it important clinically? That is more important. So you can spell it like dentin, or you can spell it like dentine. Whatever you are going to spell, it is the same thing. It is a calcified tissue of the body, and along with enamel, cementum, and pulp, it is one of the four major components of teeth. Usually, it is covered by enamel on the coronal side and cementum on the radicular side. And it actually surrounds the whole of the pulp. Dentine provides bulk and also provide the shape or the general form of the tooth. It also determines the shape of the crown. Physically and chemically, dentine resembles very closely to the bone. But there are certain differences between the bone and the dentine. Like in dentine, we have odontoblasts, and in bone, we have osteoblasts. When the bone is being formed, some of these osteoblasts, they are being enclosed within the matrix, and we call those osteocytes. Whereas dentine does not contain any cells within it, rather the processes of the cells, which we call the odontoblastic processes, they are being contained in the dentine. Well, both are considered vital because they contain living protoplasm. When we look over here, dentine has certain junctions like dentino-enamel junction or dentino-enamel junction, whatever you call it, with enamel. Then the dentino-pulpal junction with the pulp. And actually, odontoblasts are lined along the dentino-pulpal junction. And then the dentino-cemental junction in the radicular area. When we look at the physical properties of the dentine, it is light yellowish in color, and it becomes darker as a person ages. It is viscoelastic in nature, so upon pressure, it can be slightly deformed. It is slightly harder than bone, but is quite softer as compared to the enamel. It has lower content of mineral salts in dentine, and it renders it more radiolucent as compared to enamel. So in one of the lectures, we will discuss about the relative radiolucencies of different parts of the teeth, as well as the different filling materials, as we will be processing, we will be proceeding with all these lecture series. So maybe one day we will be discussing that as well. Let's look at the chemical properties of the dentine. Dentine consists of 35% organic matter and water, and 65% it is inorganic. The organic substance consists of collagenous fibrils and a ground substance of mucopolysaccharides, which are proteoglycans and glycoaminoglycans. Inorganic part, it consists of hydroxyapatite, just like in bone, cementum, and enamel. Organic constituents can be removed from the mineral by incineration or by a process called chelation, organic chelation. The bodies of the odontoblasts are arranged in a layer on the pulpal surface of the dentine, and only their cytoplasmic processes are included in the tubules in the mineral matrix. Each cell gives rise to one process which traverses the predentine and calcified dentine within one tubule. So one process, one tubule. And it terminates in a branching network at the junction with enamel or cementum, where it branches considerably, where these tubules, they branch out considerably. We will discuss why they branch out and what is the clinical significance in a while. Tubules are found throughout the normal dentine, and they are therefore characteristic of it. When we look at the dentinal tubules, the course follows a gentle curve in the crown, less in the root, whereas it resembles an S curve, like very accentuated curve in the coronal area. It starts at the right angles from the pulpal surface. The first convexity of this doubly curved course is directed towards the apex of the tooth. These tubules end perpendicular to the dentino-enamel and dentino-cemental junctions. Again, they start at the right angle, they terminate at the right angle, but between these two right angles, there is a curve which is accentuated in the coronal area and not very accentuated or not very prominent in the radicular area. Near the root tip and along the incisal edges, the cusps, the tubules, they are almost straight. Here we can see these S curvature of the dentinal tubule. When it terminates near the pulp, it is straight. When it terminates at the enamel, it is straight. Similarly, when it terminates at the cementum, it is straight. It is at 90 degrees. But in between, there is an S curvature. It is more prominent in the coronal area, but less prominent in the radicular area. Here we can see an electron micrograph, and we can see its very prominence in the coronal area. This is the enamel, and yes, very important point is that the dentino-enamel junction is not a straight line. Rather, it is kind of a sinusoidal, or you can say a corrugated type of appearance. These are the dentinal tubules, as I was telling you. So S-shaped curvature. The ratio between the outer and inner surface of dentine is almost 5:1, and the ratio between the numbers of tubules per unit area on the pulpal and outer surfaces of dentine is almost 4:1. So more number of dentinal tubules towards the pulp as compared to towards the dentino-enamel junction. There are more tubules per unit area in the crown than in the root. The dentinal tubules have lateral branches throughout the dentine, which are termed as the canaliculi or microtubules. A few dentinal tubules extend through the dentino-enamel junction into the enamel, and we call those enamel spindles, like this. Here we can see the lacunae canaliculi of the dentinal tubules. Peritubular dentine. The dentine that immediately surrounds the dentinal tubules, that is called peritubular dentine, just around the tubule. It is more highly mineralized than the intertubular dentine. Intertubular dentine is between two adjacent tubules. It is twice as thick in outer dentine, approximately 0.75 micron, than in the inner dentine, which is 0.4 micron. By its growth, it constricts the dentinal tubules to a diameter of 1 micron near the dentino-enamel junction. Organic matrix is lost along with the mineral after decalcification. The calcified tubule wall has an inner organic lining termed the lamina limitigans, high in the glucosaminoGlycans. Here we can see this is the dentinal tubule, this is the peritubular dentine, and the dentine between the two adjacent tubules, that is the intertubular dentine. Here we can see a better photomicrograph. These are the dentinal these are the odontoblastic processes, and these are the dentinal tubules. Intertubular dentine, it forms the main body of dentine, as we have already seen it over here. More body, like on the whole body of the dentine, it is composed of the intertubular dentine. It is located between the dentinal tubules, or more specifically between the zones of peritubular dentine. Its organic matrix is retained after decalcification. About 1/2 of its volume is organic matrix. Specifically, collagen fibers, the fibrils range from 0.5 to 0.2 micron in diameter and exhibit cross-bending at 64 micron intervals, which is typical for the collagen, and that makes the meshwork of the collagen. Predentine. It is located adjacent to the pulp tissue. Like this is the dentine which is laid, the process is continuous and it is being laid just before mineralization. That is called predentine. It is 2 to 6 micron wide depending on the activity of the odontoblast. It is the first form, not the very first form dentine, which is mental dentine. First form dentine means it is the dentine which is formed before mineralization. Once it is mineralized, it will be considered as dentine. As the collagen fibers undergo mineralization at the predentine dentine front, the predentine then becomes dentine and a new layer of predentine forms circumpulpally. Like over here, we can see that this is the predentine. These are the odontoblasts. This is the pulpal side. And over here, we have ameloblasts, which are depositing the, laying down the layer of enamel. Odontoblast process. They are the cytoplasmic extensions of the odontoblasts. The odontoblasts reside in the peripheral pulp at the pulp predentine border, and their processes extend into the dentinal tubules. The processes are largest in diameter near the pulp and taper further into the dentine. The odontoblast cell bodies are approximately 7 micron in diameter and 40 micron in length. Like over here, we can see this is the predentine, this is the pulpal area, and this is our odontoblastic these are the odontoblastic processes which are contained in the dentinal tubules. And over here we have interdental dentine. This is the, I will just enlarge it to make it more clear to you. This is the peritubular dentine, and over here you can see the communication is also there. As we reach close to the dentino-enamel junction, I have already mentioned that it is a corrugated surface, not a straight line. So in this area, they start branching out more. This is the first form layer of the dentine, which we call mental dentine. Cavity preparation and the dentino-enamel junction sensitivity. The dentino-enamel junction is the most sensitive portion of a tooth because odontoblastic processes, they branch considerably at this region, which I have already mentioned. So that is why this area is very sensitive to cavity preparation. Primary dentine. Mental dentine is the first form dentine in the crown underlying the dentino-enamel junction. It is the outer or most peripheral part of the primary dentine and is about 20 micron thick. The fibrils found in this zone are perpendicular to the dentino-enamel junction. Circumpulpal dentine forms the remaining primary dentine or bulk of the tooth. It represents all of the dentine formed prior to the root completion. The fibrils are much smaller in diameter and are more closely packed together. Slightly more mineral content as compared to the mental dentine in primary dentine. So over here we can see this is the mental dentine, this is the pulpal area, and here we have now the primary dentine being formed. Primary dentine continues to form till the apex is closed. Secondary dentine. A narrow band of dentine bordering the pulp and representing the dentine formed after the root completion and after the apex is closed. It contains fewer tubules than primary dentine, and the deposition of secondary dentine continues throughout the life. There is usually a bend in the tubules where primary and secondary dentine interface. Yes, keep in mind, throughout the life means life of the tooth. When the tooth is vital, when the pulp is functioning properly, and odontoblasts are alive. So over here, we can see the demarcation line. When the primary dentine is finished and the apex is closed, after that, the secondary dentine starts forming, and there is always a very accentuated line over here, which we call the demarcation line. Incremental lines. The incremental lines of von Ebner or imbrication lines, they appear as fine lines or striations in dentine. They run at right angles to the dentinal tubules, and these lines, they actually reflect the daily rhythmic recurrent deposition of dentine matrix. Well, at times the dentine formation is quite progressive or is very fast, and at times it is at the normal pace. So looking at the von Ebner line, we can also check that when the dentine formation was more as compared to other days. The course of the lines indicates the growth pattern of the dentine. Some of the incremental lines are accentuated because of disturbances in the matrix and mineralization process, like because of any reason, and those lines we call as contour lines of owl. Here we can see the incremental lines. At times these lines, they have more deposition, and at times not that much deposition. These are the lines of owl. These are the lines of owl in the radicular area and in the coronal area. These lines, they represent hypocalcified bands. In the deciduous teeth and in the first permanent molars, the prenatal and postnatal dentine is separated by another accentuated contour line, which we call neonatal line. This line actually represents or reflects the abrupt change in the environment from the womb of the mother to the real world out. So that occurs at birth, and that neonatal line represents that abrupt change in the environment. The dentine matrix formed prior to birth is usually of better quality than that formed after the birth. Here we can see neonatal line in enamel and neonatal line in dentine. Interglobular dentine. Sometimes the mineralization of dentine begins in small globular areas that fail to fuse into a homogeneous mass, and this results in zones of hypomineralization between the globules. These zones are called interglobular dentine. It forms in crowns of teeth in the circumpulpal dentine area just below the mental dentine, and it also follows an incremental pattern. The dentinal tubules pass uninterruptedly, thus demonstrating a defect of mineralization and not of matrix formation. Here you can see the globular mineralization. These are the odontoblasts. This is the predentine being laid down. This is the pulpal area. This is dentine, which is mature dentine. Here, enamel, and as I have already mentioned about the corrugated appearance of the dentino-enamel junction, and here you can see the interglobular dentine, which is slightly hypocalcified. Granular layer. There is a zone adjacent to the cementum that appears granular. This is known as the Tomes granular layer. Slightly increases in amount from the cemento-enamel junction to the root apex. It is caused by coalescing and looping of the terminal portion of the dentinal tubules. The odontoblast initially interacts with ameloblasts or root shed cells through the basal lamina. Here we can see the granular layer of domes. This is the cementum area, this is the dentine, and here the dentinal tubules, they coalesce to form the granular layer of domes. Granular layer of domes. This is the cementum, this is the dentine. Well, theories of pain transmission through dentine. There are actually three theories. And the most important and most convincing is hydrodynamic or fluid theory. Well, one theory says that there is direct conduction theory, which is in which stimuli directly affect the nerve endings which are present in the tubules. Another one, which is transduction theory, it says that the odontoblastic processes, they conduct an impulse to the nerve endings in the predentine, odontoblast zone, and the pulp. Well, as I have mentioned that the fluid or hydrodynamic theory is the most acceptable one, in which stimuli cause an inward or outward movement of fluid in the tubule, which in turn produces movement of the odontoblast and its processes. I have mentioned in my previous lecture as well how the different stimuli, they affect the dentinal tubules. So over here, just to give you the idea of these three theories, one, they say that the nerves are present in the dentine, and in another one, they say that the odontoblast, they work as a receptor and they conduct the stimulus, the pain stimulus to the odontoblast, and then the impulse is being conducted all the way to the brainstem. Well, this is the hydrodynamic theory in which the fluid, its movement, it causes pain pressure or the aspiration of the odontoblasts and causes the pain or sensitivity. Age and the functional changes. Vitality of dentine. Odontoblasts and its processes are an integral part of dentine. If they are not present, dentine is not considered as vital or living. In the presence of odontoblasts, then only the dentine is going to react to the physiologic and pathologic stimuli. Reparative dentine, also known as tertiary or response dentine, if by extensive abrasion like in bruxers, erosion, caries, or operative procedures, the odontoblast processes are exposed or cut, the odontoblasts die, or if they live, they start depositing reparative dentine. Reparative dentine is very haphazard in appearance. It is not something very regular, not with the incremental lines, not having the same pattern as of the primary dentine and as of the secondary dentine. Origin of the new odontoblast is from the undifferentiated mesenchymal or perivascular cell. It has fewer and more twisted tubules than normal dentine. Sometimes a combination of osteodentine and tubular dentine is also seen. Odontoblasts lay down almost 1.5 micron dentine per day. Here you can see a carious tooth. So the carious dentine, in which the bacteria will be present in the dentinal tubules and they are coming closer to the pulp in order to provide a shield to the pulp. The mesenchymal cells, they are being differentiated into odontoblasts and they start depositing the reparative dentine or tertiary dentine. Well, when you perform some operative procedure on the tooth, we see a calciotraumatic line, which is in response of cavity cutting or in crown preparation. The response that is going to create this calciotraumatic line, which is an accentuated band under the cavity, and it represents an acute arrest in the odontoblastic activity as a result of the operative procedure. The following notations are used for the assessment of the acute calciotraumatic effect. 0 means it is normal. Calciotraumatic effect absent or no difference between the calciotraumatic effect under the cavity preparation and the control areas or control tooth. Then number 1, which is very faint accentuation of the calciotraumatic line under the cavity as compared to control areas. It reflects a slight injury to the odontoblasts. And when the trauma is really severe, when the stimulus is very strong, then we have a definite accentuation of the calciotraumatic line. Classification of dentine on the basis of location, pattern of mineralization, and developmental pattern. So firstly, look at the location. Intertubular dentine, it is found around and between the dentinal tubules. Intratubular dentine, it is found and formed within dentinal tubules. We call it peritubular dentine. Then the mental dentine. It is formed initially in the crown, in the outer, or it is the outer corner dentine. It is the first formed layer of the dentine. Then the circumpulpal dentine, which is closest to the pulp, formed in crown after the mental dentine has been deposited. When we look at the pattern of mineralization, so we classify as globular dentine formed from the calcospheroids, interglobular dentine, hypomineralized dentine between mental and circumpulpal dentine normally and only found in the corner dentine. Tomes granular layer, I have showed that to you, that is found close to the cementum. Cyclerotic dentine, it is formed in response to some external stimulus which is really strong. When we look at the developmental pattern, there are 3 classes of dentine according to that. Primary dentine, formed prior to and during the active eruption. Secondary dentine, once the eruption is completed, root is completed, and apex is closed. Tertiary dentine, in response to some external stimulus which is very, very strong. Deadtrips. Well, the odontoblast processes, they disintegrate, and the empty tubules, they are filled with air. Those are called dead tracts. And once these dead tracts, if they are blocked towards the pulp, they are also known as blind tracts. They appear black in transmitted light and white in the reflected light. Often observed in the area of narrow pulpal horns because of crowding of the odontoblasts. They demonstrate decreased sensitivity. They appear to a greater extent in the aged teeth. Probably the initial step in the formation of sclerotic dentine is the formation of dead tracts. It could be a possibility. Sclerotic or transparent dentine. Keep in mind, sclerotic dentine is transparent. Collagen fibers and apatite crystals, they begin appearing in the dentinal tubules. Apatite crystals are initially only sporadic in a dentinal tubule, but gradually fill it with a fine meshwork of crystals. Gradually, the tubule lumen is obliterated with mineral, which appears very much like the peritubular dentine. The refractive indices of dentine in which the tubules are occluded are equalized and such areas become transparent. They are found especially in roots. Transparent or light in transmitted and dark in the reflected light. Now, certain clinical considerations. The rapid penetration and spread of caries in the dentine is the result of tubule system in the dentine. It takes couple of years, like 6 to 8 years, before the enamel is being penetrated throughout the all the way up to the dentino-enamel junction. Over here, I would like to tell you certain things. First of all, let me just select the pen. Yeah. First of all, keep in mind when the proximal caries they start at the inner surface of the enamel, never at the outer surface. And when we look at the X-ray, they appear in the form of a triangle. The triangle base is towards the outer surface and the apex is towards the dentino-enamel junction. Once it crosses the dentino-enamel junction, again another triangle is formed and its base is towards the dentino-enamel junction and apex is towards the pulp. So it takes a couple of years before the cavitation is going to occur, and the process will be within the enamel, outer layer will be intact. That is why we emphasize in case of enamel caries only in the proximal area or in a smooth area, do not go for any unnecessarily cavity preparation. Only rely on good oral hygiene maintenance and application of fluoride. What is going to happen with that? The remineralization starts occurring and fluorapatite crystal is going to be formed and the process is going to be arrested. Well, once the cavitation is there, then definitely you have to go for the restoration. So if you remember this formula, no cavitation, no restoration, you will be safe. It takes a couple of years, like 6 to 8 years, before the cavitation is going to be formed. Once it is through the dentine, then the resistance is very low because of the dentinal tubules, and bacteria, they start penetrating at a faster rate. Just a minute. Affected and infected. Sorry, another thing. After that, the dentinal tubules form a passage for invading bacteria. I have already mentioned that may thus reach the pulp through a thick dentinal layer. Air-driven cutting instruments cause dislodgement of the odontoblasts from the periphery of the pulp and their aspiration within the dentinal tubule. And we have already discussed about the sensitivity of the dentine. We will discuss smear layer as well just in a couple of minutes. We have already discussed about the sensitivity of dentine. Affected and infected dentine. Infected dentine is the outer layer and is softened and contaminated with bacteria. It is irreversibly denatured and cannot be remineralized. Whereas affected dentine, it has a demineralized phase but is not yet invaded by the bacteria, so can be remineralized. We have to make sure that we remove all the infected dentine but leave the affected dentine. And then we apply calcium hydroxide over there. Calcium hydroxide has very high pH and it actually minimizes the bacterial load and helps in remineralization, the natural process of that area. We put the base and then we go for the final restoration. Keep in mind the old concept of having a temporary filling in a deep cavity is obsolete now. No matter you are doing a deep filling or you are going for the indirect pulp capping or you are going for the direct pulp capping, after placing calcium hydroxide as the liner, then you should go for the base material. Base material preferably should be either RMGIC or if not RMGIC, it should be GIC. And then because there will be very minimal leakage in those two cements, preferably RMGIC. And then you should go for the final restoration in the same setting. There is no intermediate restoration, no primary filling or things like that. It is just like, or temporary filling, nothing like that. In clinical restorative treatment of dentine during cavity preparation, it is infected dentine which is completely removed. I have already mentioned the affected dentine which may be remineralized after the completion of restorative treatment is not removed and we preserve it. Caries affected dentine interfaces showed a much thick hybrid layer than was seen on the non-carious layer. I will come to the hybrid layer in a while. Hybrid layer is the layer which is formed between the composite and the dentine. We will come to that point in a while. Presumably, the thicker hybrid layer in caries-affected dentine may be due to the fact that caries-affected dentine is partially demineralized and is more porous as compared to the non-carious dentine. So when it is more porous, there will be increased number of resinous tags over there. It allows deeper penetration of the acid agent, leading to a deeper demineralization with diffused monomer in that area. Certain clinically important points. Bulk of the remaining dentine is very important while preparing a tooth for a restoration. If very thin dentine is left, you have to be very, very careful at that time. Choose that kind of base material which would be biocompatible, either polycarboxylate cement or glass ionomer cement. Never use zinc oxyphosphate when the very thin amount of dentine is left over there. Again, based on the bulk of remaining dentine, we decide whether to give a pulp protection or not. A liner is required or not, a base is required or not. While selecting a base material, we gave greatest consideration to the amount of remaining dentine. What is a smear layer? It is an adherent layer of debris and can be found on tooth surface after having been cut with either rotary or hand instrument. It consists primarily of shattered and crushed hydroxyapatite and fragments of collagen, bacteria, and saliva. Average thickness of this smear layer is 0.5 to 2 micron. Very irregular morphology. Smear layer morphology depends on technology used for cavity preparation by air abrasion, laser ablation, or manual preparation. It has advantages as well as disadvantages. Advantage is when the smear layer is present, it reduces the dentine permeability by 86%, as well as sensitivity is reduced. It is attached weakly to dentine but cannot be removed just by rinsing. Here you can see this is the dentinal tubule, this is the smear layer plug, and this is how the smear layer is. You cannot remove it simply by water and air spray. You need to acid etch in order to remove the smear layer. The disadvantage is it is blocking the dentinal tubule, so your composite cannot get the retention, the micromechanical retention which you require. That's why you need to remove it. Now, let's see conditioning of the dentine at a glance. Firstly, when you do the conditioning, it removes the hydroxyapatite layer. Then the microporous collagen network is created. Here we can see this is the precondition. After conditioning, you can see the fibril network of the collagen. And keep in mind, when you are washing the dentine after etching, do not desiccate it. Just simply blow away some water. You need some water in this area for the integrity of this collagenous network. If you will dry this area, I will show you in a while, like in the next slide, that how the collagenous fibrils, they will collapse. So we will be having partially open dentinal tubules by this process of dentinal conditioning or dentinal etching. So over here we can see this is the smear layer, and after you do the etching, we have this wet collagen. We want this type of collagenous network in order to get the hybrid layer. If you will desiccate it, it will be totally collapsed, and it will be like not good for making the tags over here, the resinous tags. Hybrid layer in dentine bonding. So this hybrid layer is in the interdental dentine, like the intertubular dentine and the resin. These are the dentinal tubules. So over here, we are done with our this lecture, and we will definitely continue our series of lectures as all of you want it, and I will be available to you.
Thank you, sir, for the today's lecture. It was very good. If anyone wants to ask sir any question, he or she can kindly post it in the live chat in the comment, or can email me or to the sir email ID, so that the question will be answered by you.
It is better to send the to post the questions underneath the live streaming, which you are going to post it in the group, and it will be easier for me because I receive so many emails every day. So probably I may miss one of the questions, which would be very important. So in order to get your query or your question addressed at a very early time, and please post your in the comment box in the group, and I will definitely respond.
Okay, thank you, sir, for the today's lecture. Inshallah, we will continue on next Monday with the next topic. Inshallah.
Inshallah.
Khuda Hafiz, sir.
Allah Hafiz.